All right, good morning to everyone. Hope everyone's doing well this morning. We here for grand rounds this morning. A couple of resident talks with some interesting titles. Looking forward to hearing from everyone. The CME color for this morning is going to be silver, and I think that is the only announcement right now. I think Dr. Hysong I see here, so I'm assuming you're going to be our first speaker this morning. So Dr. Hysong is going to be talking to us about one of all of our favorite diagnoses. I know that when I'm on trauma call, I love getting a call that mentions necrotizing fasciitis. Always is up for a fun night to follow. So Dr. Hysong, we'll let you share your screen and tell us a little bit all we need to know about necrotizing fasciitis.
Thanks, Dr. Pat. So can everybody see my screen?
You are good.
Perfect. All right. So as Dr. Pat mentioned, I'll be giving my grand rounds today on necrotizing fasciitis, and specifically, I'm going to be focusing on the molecular pathophysiology of this disorder to hopefully give us a better understanding of our clinical management and appreciation of this pretty complex and scary disease. I have no financial disclosures related to this topic. And we'll start with a case, a 12-year-old female. She was previously healthy. She's had 3 days of a febrile illness, sore throat, and GI symptoms. On day 4, and keep in mind, this is a representative image. I didn't have images from the actual case, unfortunately. On day 4, she developed a cellulitic appearing rash on her right lower extremity. She had excruciating pain at the area of erythema, and also it radiated up into her groin. She presented on that day to the emergency department for evaluation, and labs were drawn. While awaiting results for her labs, she actually became acutely hypotensive. Supportive measures were initiated. Antibiotics were given. She was taken to the ICU and ultimately was intubated for management. Her rash continued to worsen throughout the course of all these changes. Orthopedics was consulted at this time to evaluate and rule out necrotizing fasciitis. And notable labs at this time were CRP elevated at 150 and platelet count or thrombocytopenia at 49,000, and 150 on atrium scale with our labs would be 15. So what is it? Well, we know her diagnosis is going to be necrotizing fasciitis based on the title of this talk, but in simple terms, necrotizing fasciitis is a rapidly progressing destructive infection. It elevates fascial planes, causes exorbitant inflammation, and potentially results in death. But why do we, a bunch of bone-loving jocks, why do we care as orthopedists about this disorder, a disorder we can't plate and nail? Well, if we look at the statistics here, in some studies, over 50% of cases involve the extremities, and at most centers, this actually makes this an orthopedic issue. It's pretty rare, and not so much at tertiary care facilities like Atrium, or like CMC, but there's a very low incidence in the population, and that makes it really difficult to study. There's not a lot of randomized controlled trials about necrotizing fasciitis and its management. Many physicians aren't used to diagnosing it and not used to seeing it. And this can lead to a lot of false alarms and boy who cried wolf scenarios. But when it's real, and most of us know this, it's very scary. It's swift and deadly. It can increase at a rate of 2 to 3 centimeters per hour up an extremity. So it can start at this benign appearing cellulitic rash on somebody's lower extremity. And then in a matter of hours, it can progress up the entire extremity, starting to cause skin necrosis in association with the very grim clinical picture. Mortality rate, even in the era of modern medicine, is exceedingly high. Some studies report a rate of 45%, reaching 100% if untreated. And if patients start to clinically decompensate, it's often too late even for surgical measures. Morbidity, even if patients survive, is high as well, with an amputation rate of upwards of 20%. So prompt treatment is critical. And that makes the scariest thing of all the rate-limiting step in the early management of these patients, the junior residents on call. The least experienced people in the hospital are responsible for seeing these patients, triaging them, and initiating care. And we know that that's the most important step in the management of many of these patients. So how do we ensure that these junior residents, that these early physicians that are evaluating necrotizing fasciitis are confident in their decision-making? Well, one easy way is to start with an injury, and we'll conceptualize it with the bone, so we're all familiar with the terms here. But starts with an injury, and every injury at its core is a breach of compartments. And this leads to 4 potential problems: bleeding, infection, hypoxia, and soft tissue dysfunction. This activates a term that, or a process which some of us have heard about, the acute phase response. You get IL-6 released from the area of injury, which travels to the liver, and you get thousands of acute phase reactants, which are produced. These problems are resolved in order, with coagulation stopping bleeding, inflammation or coagulation actually walling off potential pathogens, and inflammation killing these pathogens, angiogenesis resolving hypoxia, and ossification resolving soft tissue dysfunction. Importantly, these problems are actually resolved in order. It starts with coagulation, and as I presented them, goes down to tissue healing. And I used ossification because this is bone, but just soft tissue healing in general to resolve the issue. And then these categories, or these processes, can be further divided into 2 overarching categories of survival, where you have temporary containment of the issue, allowing the patient to survive the immediate injury, and then repair, where you ultimately get a permanent solution for the problem. My lab in medical school conceptualized this process through a graph. You have early, your single injury response, where you have hemostasis peaking early, and then there's survival inflammatory response. So you have hemostasis and clots walling off, bleeding, and inflammation killing infection. And then you move into your repair phase once those issues are dealt with, and you have targeted fibrinolysis or planned clot breakdown, paving the way for angiogenesis and tissue repair. Important players in these steps in necrotizing fasciitis are fibrin and platelets, and hemostasis, and inflammation, neutrophils and T cells. And then activated plasmin is what catalyzes fibrinolysis. So what does necrotizing fasciitis do? Well, it hijacks this acute phase response, and it uses it against us, and we'll see that shortly. The key players in necrotizing fasciitis, they're typically categorized into 3 groups, type 1 and 2 being the most common. Type 1 is polymicrobial. It typically affects our more elderly and sicker populations. And type 2, the more classic presentation of necrotizing fasciitis, is monomicrobial and caused by group A strep. It can affect any patient in the population or any age group, like the patient in our case presentation, and it typically involves the extremities over the trunk. Type 3 we won't focus on for this talk. And an important point is that even in type 1, these polymicrobial subtypes, strep species are the most commonly isolated bacteria from these groups. So yeah, when we focus on type 2 to create this conceptual framework, we're talking about group A strep. And yes, the same exact strep that causes, or the same bacteria that causes strep pharyngitis. How does it go from that to destroying extremities and killing patients? Well, the answer is evolution. Strep pyogenes has evolved. You get a tissue injury and an immediate fibroplatelet plug trying to wall off infection with group A strep that's inoculated the area. It can also seed through hematogenous spreading. But as we said, group A strep has evolved, and one of the very important exotoxins or virulence factors that it's created is streptokinase. And what streptokinase does is it constitutively activates plasmin, and it cannot be turned off by normal mechanisms. You get rampant early fibrinolysis, breaking down clots that attempt to wall off infection. Additionally, as we know, neutrophils lyse to form DNA webs to trap bacteria and form pus. But what actually happens is group A strep has created DNase B, which breaks down these webs. And these aren't the only virulence factors that group A strep produces, but 2 of the important ones that allow it to evade containment. And this allows it to divide and spread. Proof of concept of the importance of streptokinase in particular in necrotizing fasciitis was published in 2004 in Nature. They attempted to inoculate healthy mice with group A strep that caused neck fash in humans. But they found that it was ineffective in making these mice ill. That wasn't until they created humanized mice with humanized plasminogen in particular. And they soon found that the bacteria rampaged through the mice, giving them necrotizing fasciitis and killing most of them, proving or showing that this manipulation of the coagulation cascade and fibrinolysis is extremely important in this disease process. So another representation of this process is you have an injury in the soft tissue, fibrin platelet plug that forms there. And then you have group A strep inoculating the area. Streptokinase comes in and activates plasmin. and starts to spread under a fascial plane. It encounters a fibrin web and destroys it. DNA ASB breaks up plate or a DNA web, and then you get this rapid destructive infection with significant edema. And no purulence is often what is described when these patients are operated on. You get this quote unquote dishwater fluid presentation of the infected area. And that's because it's breaking down all these containment mechanisms of the body. Another very important streptokinase exotoxin that we'll focus on, and the last one we'll focus on, is M protein. M protein, amazingly but unsurprisingly, actually forms a complex with fibrin. It forms this complex with fibrin and it's released by group A strep. And it turns into a superantigen, which activates T cells and leads to an extreme, exorbitant hyperinflammatory response. And this is often the kiss of death in these patients, and this leads to rapid decompensation. So if we go back to our graph of the acute phase response, we'll see that even in the absence of superantigen or superantigen causing streptococcal toxic shock syndrome, this early activation of fibrinolysis and evasion of containment leads to a prolongation of this survival acute phase response. It's a positive feedback loop, and you get the body continually attempting to wall off infection and continually increasing its inflammatory response, both as soft tissues are injured and as it attempts to trap and kill infection. And this leads to issues. So what kills you? Well, I just alluded to it. Hyperinflammation and a breach in containment leads to consumptive coagulopathy and DIC. Hyperinflammation also leads to shock and multi-organ dysfunction. And in some cases, these two conditions combine, and this isn't always what occurs in these patients, but you can see what's termed CIRCI or critical illness-related corticosteroid insufficiency. And this is a state where the hypothalamic adrenal axis is disrupted through multiple mechanisms. And you actually have patients that either aren't producing enough or aren't responding to cortisol or ACTH, and you get vasopressor or vasopressor resistant or refractory shock. So how do we beat it? Well, I mentioned this before. We catch it, and we catch it early. Early diagnosis and aggressive surgical debridement are the cornerstones of treatment in necrotizing fasciitis. And in order to catch it, our first, second, and third priorities on call when we're seeing it are our exam. And it's easy to catch, or relatively easy to catch, necrotizing fasciitis when it looks like this, but this isn't when you want to catch it if you can avoid it. You want to catch it or start to be suspicious of it when it looks like this, a benign appearing cellulitic rash. In fact, the admitting diagnosis in some studies is cellulitis in over 50% of cases and under 20% necrotizing fasciitis at admission. So how do we avoid this misdiagnosis? Well, I created this acronym based on my research of PRP, the three most common presenting symptoms when you're evaluating somebody with necrotizing fasciitis. The first is pain. And often it's reported as pain out of proportion. And that can be kind of ambiguous, but I mean, we know it when we see it. But some objective terms that you can associate with that are pain extending beyond the area of erythema and the area of swelling in the lower extremity, and crescendo pain or worsening pain. We know this is a progressive injury and it progresses quickly. So that's a very important finding when we're evaluating these patients. And if we look back at the pathophysiology, it makes sense. Whether or not this is actually what's happening, it's an easy way to conceptualize it. You see this area of erythema in the lower extremity, and more proximally, we see that even though there's no edema or erythema there, what's likely occurring is these rapidly evading and destructive group A strep molecules are progressing underneath fascial planes, and they're causing pain and soft tissue destruction and microemboli. And in their wake, they lie this hyperinflammation and vasodilation, which leads to erythema and edema. This is just an article which talks about the importance of crescendo pain and probably one of the most important findings prior to decompensation in these patients. Redness or erythema, it makes sense. It's one of the more common presenting symptoms. As I said, cellulitis is a very common misdiagnosis. And one important thing is that, or one important feature is that can often have indistinct margins. Cellulitis typically, which is isolated to our fat layer, typically has a well walled off or contained border. And obviously this is an uncontained infection, but this hyperinflammation and capillary leak is leading to edema and blood near the surface. And finally, the last P, or probably the most important, is progression. Progression, we know this is a rapidly moving disease, and it's going to progress if someone has it. And probably one of the best ways to catch it is what people often do when they're concerned about it is wall it off with a Sharpie or mark the proximal extent with a Sharpie, time and date it, and evaluate it regularly within the hour, within 30 minutes, depending on how concerned you are. And if you see it progress, your concern should really peak, and it might be that at that point in time that you start to call your senior or start to initiate management for a necrotizing fasciitis type picture. Later or hard signs of necrotizing fasciitis or bulla or hemorrhagic bulla, which makes sense as we have if we have vasodilation locally leading to blister formation or bulla formation, and then tissue death and direct derangement of our coagulation cascade could lead to bleeding into these bulla. Fluctuance and crepitus occurring through the same, or fluctuation and skin necrosis occurring through the same mechanisms. Crepitus is present if you have a gas-forming bacteria. And sensory and motor deficits can be found when soft tissues or when the bacteria starts to injure our neurovascular structures. And then finally, signs of decompensation, particularly hypotension and tachycardia. These are really concerning because this means that these patients are starting to fall into that category of hyperinflammation, either toxic shock or just a massive evasion of containment. And they're starting to develop shock type symptoms and can go south quickly. Fever may present earlier, but it only presents on admitting in about 50% of cases based on the table here. So what about labs? Well, labs should be used as adjuncts to intuition. And these are common labs that we'll see on patients when we're getting consulted to rule out an infection or evaluate an infection or evaluate necrotizing fasciitis, but they should really only be used as adjuncts to our clinical intuition. We'll address the elephant in the room, the score that almost everybody knows about, the Lernex score, the laboratory risk indicator for necrotizing fasciitis, developed in 2004 by Wong. It was initially touted as having a very high positive predictive value and being a tool to screen patients for nec fasc. Subsequent studies, which I won't go through each of these that are listed here, have shown that while it is a specific lab metric or a scoring system, it's specific when patients are well into their course typically, and they're pretty sick. It's not a very sensitive tool, and it's not a great screening tool for necrotizing fasciitis. So instead, I propose we focus on what we know, and we know what hurts us and what we're worried about in nec fasc. The first is hyperinflammation, where it all starts, and an excellent marker of this is CRP. And how does CRP work? Well, if you look at the area or our injury model again, we get IL-6 production, which travels to the liver, and an acute phase response activation leads to CRP production, an acute phase reactant. And it can often be conceptualized as being proportional to the degree of injury or soft tissue injury. Multiple studies have shown that CRPs of greater than 15 or greater than 20 have the highest odds ratio of a patient having necrotizing fasciitis compared to other types of infection like cellulitis or abscess on their admitting lab values. And Borschitz et al. In 2015, he showed that CRP was 5 times higher in necrotizing fasciitis cases when compared to non-nec fasc cases. Other markers such as ESR and white blood cell count are very good lab values, but they're not as reliable and they don't raise as quickly often or respond as reliably as CRP does in these patients. And then we start to think of a more general category like shock and organ dysfunction. And a lot of lab values can fall into this, but we need to think we're worried about somebody that's falling into a shock or a SIRS state or septic state. So you start to think about your lab criteria for your SOFA score, your severe sepsis and SIRS. Elevated lactate being one of these very important values, which we may or may not have when we're initially being consulted or initially seeing these patients, showing evidence of soft tissue hypoperfusion. Low hemoglobin can be a sign of hemolysis, both through the bacteria and if your patient is developing a DIC type picture. Elevated blood glucose being representative of soft tissue misuse of glucose. Elevated creatinine from hypovolemia and from microthrombi in the kidneys. Hyponatremia can be a sign of hypovolemia due to third spacing and SIADH. It can also be a sign of adrenal dysfunction if somebody's going into a Surkey type picture. DIC and consumptive coagulopathy. Well, we know that sepsis in general can cause a coagulopathy, both through hyperinflammation, but we also know that necrotizing fasciitis itself, particularly in the group A strep variant, is directly manipulating our fibrinolysis or fibrinolytic cascade, and we're consuming our clotting factors in order to wall it off. Often we'll have platelets and INR early when we're evaluating these patients. If platelets are low, like in our case study listed earlier, we should be concerned. INR can be a sign of consumption of vitamin K dependent factors. And if we see that these are deranged or platelets are low, INR is high, this can spark our concern for a DIC type picture, even if we're just the consultants evaluating. And we can order labs like fibrinogen, D-dimer, activated protein C activity, in order to further elucidate how severe their coagulopathy is. And then briefly, CIRCI in a patient with refractory shock can be shown through a random cortisol or an ACTH stim test. We won't be the team ordering these, but it's something to be cognizant of. And imaging. Imaging is a brief topic when talking about necrotizing fasciitis, but it's an important one. One common statement that I've heard made is that the patient didn't have gas. I'm not worried about necrotizing fasciitis. And a very important point is that gas is really only present if a patient has like a large decubitus ulcer or more typically if it's a Clostridial species that's causing the neck fash. And if it's present, it's a hard sign and you should act quickly. But if it's not present, as it isn't in most cases of necrotizing fasciitis, you should still be concerned if clinically someone's lining up with this picture of necrotizing fasciitis. CT, MRI, and ultrasound are useful adjuncts, but they're more sensitive than they are specific. And more often than not, they're showing more of a picture of edema than anything else. The most important point about imaging is never let it delay a diagnosis, or more importantly, never let it delay treatment. So what can we do as the orthopedists on call, the orthopedic residents or the orthopedic surgeons that are on call? When we first see a patient, we can start broad antibiotics. You can see on the right here, as I said, group A strep isn't the only organism that causes neck fash. It's just used to create a conceptual framework. We need to cover a lot of different species. Gram-negative rods and anaerobes can be covered with Zosyn, MRSA with vancomycin. If we're worried about a gas-forming Clostridial species, we can give penicillin G. And probably the most interesting is one that we can even see that's administered in our power plans here at Atrium for a necrotizing soft tissue infection is clindamycin. Clindamycin is an antibiotic which kills bacteria, but the more important function is that it inhibits the 50S ribosomal subunit of bacteria, and it actually stops protein production and specifically stops exotoxin production, which is why it's administered. And probably the most important thing we can do is operate early, whether that means calling in your team or actually physically performing the surgery. Surgical intervention is life-saving and must be performed as early as possible. Studies vary, but the consensus is that less than 24 hours is associated with a decreased mortality, but earlier is always better. Operate systematically. Wong created principles in 2007 for operating on necrotizing fasciitis, confirming the diagnosis either through physical exam in the operating room or biopsy in the operating room of the fascial planes, delineation of disease extent, of complete resection of infected tissue, and adequate postoperative wound care, likely or often through the form of a wound vacuum. Some people suggest that we should treat it like a tumor, take intraoperative frozen sections in the area of infection, and use them to guide our extent of resection early and extent of debridement early, where you take these frozen sections and then find this area of healthy tissue where you have viable fibroconnective tissue, as opposed to frozen sections showing non-viable fibroconnective tissue with numerous bacterial clusters. And important point is that the only way to truly diagnose necrotizing fasciitis or to confirm it on lab value or through pathology is with an actual biopsy of the involved soft tissues. And then operate regularly. Reinspection within 24 hours is often recommended within a Q1 to 2 day repeat debridements of the area of infection for an average of 3 trips to the OR, which is typically performed on these patients who survive, always with the goal of removal of all necrotic and infected tissues. We should protect ourselves. A brief point, but an important one, is that surgeons debriding it, particularly group A strep, neck fash in the OR, are at the highest risk of actually getting nosocomial contracting nosocomial necrotizing fasciitis. It can be aerosolized early when operating around these wounds, and there are multiple case reports of patients getting strep pharyngitis or developing necrotizing fasciitis with the same genetic makeup as the group A strep that infected the patient they were operating on. People advocate for the use of N95s, which is much easier in this COVID era, and wearing it around the open wounds within 48 hours of antibiotic administration if you're in the operating room. And then finally, we can recommend the ICU. Most every one of these patients needs an ICU stay, but sometimes it's too early and people won't think that that's the case. We should at least get a consult on board to evaluate these patients and be ready to escalate management if needed. And finally, and briefly, what can the ICU do? And this is interesting because these therapeutics directly target the mechanisms of action I talked about before. Hyperinflammation and exotoxins, as I mentioned, clindamycin attacks this. IVIG, which is proposed in group A strep necrotizing fasciitis, actually binds exotoxins and inactivates them. AB103 inhibits a CD28 inhibitor, which is a T cell receptor, hopefully eliminating hyperinflammation. Shock and hypotension, obviously, to treat fluid support and vasopressors to treat this. DIC and hyperfibrinolysis can be treated with FFP and cryoprecipitate. It's important to note that FFP typically has an INR of 1.6, which is relatively hypocoagulable, and we should follow INR when we're administering it to patients. Low platelets should be treated, thrombocytopenia should be treated with platelets, and vitamin K has been proposed in some studies in order to help our body replete its vitamin K dependent clotting factors. And if a patient starts to develop vasopressor resistant shock or refractory shock, stress dose steroids have been advocated for as well. So briefly, we'll return to our case. Again, we have our initial labs in this patient. On our evaluation by the orthopedics team, the decision was made to go to the OR. And another additional lab that was obtained was a random cortisol at 7.4 in the setting of hypotension and hyperinflammation. This was prior to the OR. She was taken within the first 3 hours of her stay. An extensive debridement with negative fascial margins was performed. These are her labs post-op, pre and post-op. We can see that her MAP goals were followed or her MAPs were followed, and they were low initially in the first 24 hours. They actually ordered an activated protein C level on this patient out of concern for consumption of vitamin K dependent factors, which was low early. Clearly, she was hyperinflammatory. Her platelet counts were low, as we mentioned, and her PTINR was elevated at around 2. Stress dose steroids and pressures were administered out of concern for this Cirque type picture. Antibiotics were administered as well for her bacterial burden. And then finally, vitamin K and FFP were administered due to her coagulopathy. No platelets were given though. She survived, and her biggest complaint is knee pain, and luckily it was only with one trip to the OR. These are some summary and take-home points. Biggest points being act early, have a high index of suspicion, and use the pathophysiology that we know, this derangement or hijacking of the acute phase response to guide our clinical appreciation and management of this condition. I'd like to thank Jonathan Schenecker, my mentor from Vanderbilt, Steph Moore-Lottridge, another one of my mentors in Lou Posey as well, for reviewing this talk and helping me on research in med school. Thanks. Hopefully this was helpful.
That's excellent, Alex. Thanks for that really fantastic review of a challenging topic. It's certainly a lot of that is stuff I've never really seen or thought about. I just have the nightmare experiences of meeting someone in the OR for the first time and trying to figure out how to be aggressive enough, like you say. Brings back lots of vivid memories. I think when I took the oral boards, the most common case on my boards was necrotizing fasciitis. But as you might imagine, it was only because of one patient who I had to take back so many times that it ended up being so common. Anybody, especially our trauma folks or any ER people who might be on the phone, have any questions or comments?
Hey, Dr. Pat, I had a comment, just for kind of junior residents taking in-house call. I think this is one of those ones, kind of like compartment syndrome, where you have a subjective diagnosis. Don't be afraid to load the boat, if you're in-house and you just, convince yourself it's cellulitis, you can definitely miss some stuff. Another comment just on the system we're in, transferring patients to Mercy with diabetic foot wounds, make sure you're seeing those patients and making sure they don't have, signs and concerns of neck fash, because I've definitely seen that a couple of times. So.
Yeah, I think that your point is well taken, Nick. And I think one basic recommendation, which you'll probably agree with, that every junior resident, when you're making that diagnosis, unless the person is actively dying and you're on your way to the operating room, this is the case to get your senior resident into the hospital and examine the patient themselves, because until you know it, you don't know it. Brian.
Hey, Alex, that was a great talk. Any kind of tips just from a surgical standpoint on sort of how to get ahead of that inflammatory response? I think that's always the challenge. Surgically is sort of where to go and how far to go. Are there tips just from a pathophysiology standpoint that you or Schenecker kind of feel like this is sort of where you need to get to surgically to see this kind of plane of tissue before you end up stopping that initial debridement?
Yeah, that's a really good question. And I touched on it a little bit with that. He specifically, when I learned about it from him, really advocated for taking those intraoperative frozen sections and actually using that evidence of necrosed fibroconnective tissue to guide your extent of resection and going a little bit past that, almost treating it, like I said, like a tumor. But then another, and I didn't include this in my talk. Actually hid this slide. Let me see if I can find it real quick. There's some other studies which advocate, I think Wong, is it Majeski or Wong, one of these? Sorry, let me find this here. Talked about actually zones of injury when you're operating on this, or zones of the infection, where you have zone 1 of clearly necrotic tissue, zone 2 of this reactionary zone of kind of edematous, boggy tissue where there's not necessarily infection. And maybe even in this zone, you won't see positive biopsies if you're taking it of the soft tissue or the fibroconnective tissue. And then zone 3, and in his study, he actually advocates for resecting those first 2 zones of soft tissue to really get ahead of that bacteria, and making sure, not being generous with your resection, and making sure that, like you said, you're getting ahead of it, because that's the issue, right? It's leaving enough that it can continue to rampage through and dissect under your tissues and create hyperinflammation. So, I mean, that's the best. I don't know if anybody else has a comment, but that's what I came across and what I've learned.
Yeah, I mean, we fortunately don't see a lot of these in kids. I've had one major one, and a kid with leukemia as well, that ended up going to the ICU and still getting his chemo that night after his first surgical debridement, because we needed to, quote, stay on their protocol for their cancer treatment. So these are obviously tough in adults and as well as pediatric patients. That's what I've used, is that article to kind of guide me a little bit. I think that probably in combination with what Dr. Schenecker has talked about as far as frozen sections, I think implementing that would be the interesting piece as far as how to get that done here in the middle of the night. I think that would be the challenge looking at our institution right now. So.
Hey, Alex, it's Natty. Great talk. Just a quick question. In your research and your experience, how often does neck fash present as a post-op orthopedic infection?
There are certainly examples of that, typically that more polymicrobial form. I don't have an exact rate, but that's actually something that I've come across in research where can be a factor leading to delayed diagnosis, because in post-op infections, you're attributing it, or providers are attributing it to post-op pain or the swelling from surgery, and or like a cellulitis related to the incision, and it actually progresses and becomes a neck fash. But to be honest, I don't have an exact number. I don't know if anybody else has come across a rate of that.
Well, Alex, I'm going to bring us to a close here. Just one comment on a question in the chat. Dr. Garcia asked a very important question about how do you deal with this when you're getting a transfer call about it. when the person's going to be several hours away, knowing the progress of this. I don't have an answer to this, but it's a very real question. I literally last weekend on call got a transfer call from PCL about a patient who was being taken to the OR for aggressive neck fascia at another hospital, and they wanted to arrange for post-op transfer to CMC for his ICU care. And within 30 minutes, got a call back that the patient didn't even make it to the operating room; they died. So it's real. I mean, I think that so Ryan, I don't have an answer for your question, but it's definitely a significant issue. So thanks for a fantastic talk this morning, Alex. Great to see you incorporate some of your basic science research from med school into a real life clinical scenario. So I think all the residents are happy to know they can just call you when they have neck fascia in the ER, and you'll be happy to take care of it for them. So